Well, good afternoon, everybody. My name is Greg Olson. I'm the director of the New York State Office for Aging. Really excited about our program today. I've got two really great guests that have been on the show previously, but it's an extraordinarily important topic. What we're going to be talking about today is end-of-life care, a topic that really all families need to fully understand and talk about. Hospice care, palliative care, it's an incredibly important program that helps individuals and families at the end of life. Yet stigma, misinformation, or just a general lack of understanding as to what hospice is still exists, which is why we need to address those stigmas head on. And that's what we'll be doing today with information and facts and a little bit of myth busting. Did you know that studies have shown that patients in hospice care actually...
Now, live with Greg Olson, Director of the New York State Office for the Aging.
Let's try that again. That has never happened before, but shows that we're all human and we can adjust. So as I was saying, studies have shown that patients in hospice care live longer than they would otherwise. Many families are missing out on the potential benefits, and there's many of them due to hospice delays and late referrals or no referrals at all. And that forgoes compassionate care at the end of life altogether. For Medicare, let's talk about New York State. We love to be first in the nation, and we are in so many things, and so many things have been led over history from New York. But New York is actually last of all states, number 50 out of 50 in the proportion of individuals who receive hospice services prior to their death, something we can change. There are many reasons why this is the case, and no single reason is to blame, but you can be the solution by listening today, sharing what you hear with others, and just continue to remember. This is a program we'll probably do over and over again because it needs to be in front of people, especially as people's needs change. So I'm really pleased again to be joined again by Jeanne Chirico, who is the president and CEO of Hospice and Palliative Care Association of New York State. She's going to help us understand some of the basics about hospice and deepen our understanding of its role and importance in our healthcare and overall support system. So Jeanne, welcome back. It's great to have you.
Thanks, Greg. Great to be here.
And I'm also really pleased to have Becky Preve, who's the executive director of the Association on Aging in New York. Becky's been on the show many, many times. Her organization represents our 59 county offices for the aging, also works obviously very closely with us. And she'll talk about the role of aging service providers as a resource for families and caregivers in the hospice conversation. But Becky is also a board member, a longtime board member of Hospice of the North Country. So Becky, welcome back.
Thanks for having me.
And I want to remind everybody if you have any questions throughout the program, please put the questions in the comments section and we'll get to as many as we can at the end of the show. And also make sure that you like our YouTube page. We have tons of great content on there. We're reaching really astronomical numbers through this and other programs that we do. So let's start with you, Jeanne. What's hospice care?
Well, hospice is an interdisciplinary approach to caring for someone at the end of life that takes into consideration the whole person, the physical, spiritual, mental, emotional aspects of the individual and their entire family. So it's one of the rare things that Medicare got right when introducing a healthcare model, because it really is all inclusive of the entire family unit and it embraces all the needs of the individual and the people around them, including their caregivers.
Well, thanks for that. And your organization is Hospice and Palliative Care. So what is palliative care?
Palliative care is a comfort-oriented approach to helping manage an individual's pain or symptoms at any point in their life. So palliative care can be delivered to anyone at any age, at any point in their illness or condition. Hospice, on the other hand, is very specific and regulated and is for individuals who the physician believes has a prognosis of 6 months or less to live.
Thank you. And the facts from New York are really kind of stunning. We opened up with that. We're last in the nation. A lot of it is due to just lack of knowledge and information. So what types of services does hospice care provide?
I'd say the first thing that hospice does is help to reduce the anxiety that surrounds the unknown about dying. So the individuals that work for hospice are experts in end of life care. So there's a nurse and a physician who help to manage all the physical conditions. There's a social worker that helps the whole family unit and children who might be involved understand what's happening, and understand their own grieving process. There are chaplains and volunteers and personal care supports available to hospice. But beyond that, when someone signs on for hospice, what they're also getting is payment for the medications that they might need, payment for durable medical equipment like a hospital bed that they might need during the end of life. So it encompasses a wide variety of services.
And does hospice end when the individual dies?
Actually, hospice includes bereavement support for anyone that considered themselves a loved one of the individual that died. And by regulation, services need to be available for over a year for people who are involved. But most hospices just keep the door open to support anyone at any point that they consider the grief overwhelming and need some help.
Yeah, I mean, these programs and the staff are just absolutely amazing. Talk to us about eligibility. Who's eligible?
So as I mentioned, this is a conversation that people need to have about their loved one or themselves with the physician that's involved, because we're hoping that these conversations help elicit what a person's goals are. Because one of the goals needs to be that the individual no longer wants curative treatment, that they no longer want to go back and forth to the hospital or receive aggressive treatment that might limit their quality of life. And so to be eligible, the physician needs to acknowledge that without these additional treatments, they might have 6 months or less to live. And that's the start of the eligibility, and not going back to the hospital as a choice. That's the second part of the eligibility.
Yeah, and what I love is, none of us had any choice in how we were born, where we were born, and what families, but this provides some really important choice in how we want to end our lives. So Becky, you've been a longtime board member of Hospice of the North Country. You're also a past AAA director in Franklin County, represent the 59 county offices for the aging. They work with 1,214 community-based organizations. What would you recommend, and how would you go about not only educating our folks, but trying to get the referrals that really provide this quality end-of-life care and support that hospice provides?
So I really think it's all about communication. And, we've seen a lot of changes in the healthcare space under Medicare, observation status, those types of things. So what we're seeing is really clinically complex individuals who aren't having an extended hospital stay where they're having conversations with physicians and then discharged home, potentially having the hospice conversation. So what anybody in the community can do, and something that we work really closely with our area agencies on aging are being educated about the fact that hospice is a local resource that costs nothing to have a conversation with. And it's really important that anyone that's publicly facing that works with health and human services providers be aware of the availability of hospice, the no cost of hospice, and eligibility criteria that Jeanne just spoke to, because it's a really underutilized resource in the community and we can do a lot better job.
And Becky, what kind of type of clinicians have to refer hospice services? Is there a certain type, or is it broad?
There is no clinical requirement to do a referral for hospice services. So a family member can call, a friend can call, a neighbor can call, you can call. The conversation you have with hospice does not need to be clinician led. If you do decide to enroll in hospice, that does need to be provided by a physician to actually certify that you meet criteria. But to have that conversation, you do not have to have any clinical experience. Anybody can make that call.
Yep, and I learned that last time thanks to you guys. So thanks for clarifying that again. What are the types of clinical diagnosis that are needed, though, for an individual to qualify and receive hospice?
Well, unfortunately, and I'm sure Jeanne will chime in on this, a lot of people have this assumption or myth that you have to have a cancer diagnosis in order to enroll in hospice services. That is absolutely not correct. We see people with a variety of different chronic illnesses like congestive heart failure, end-stage renal disease, cirrhosis, really any diagnosis that then qualifies you for that 6-month or less time frame. So this thought process that my loved one does not have a cancer diagnosis is something we're really trying to combat, to say it's not just about a cancer diagnosis. It's really about any clinical diagnosis that meets that criteria.
Yeah, I would just add that I think part of why there's a misperception or myth surrounding that is because when hospice began, and our association's been around for 45 years. So when hospice first began as a benefit, the majority of individuals accessing the benefit did have a cancer diagnosis, but so much progress has been made in reversing our life prognosis with a cancer diagnosis that cancer is no longer the number one killer in our country. We have heart disease and respiratory diseases and unfortunately, a host of other things, as something will eventually take all of us, but it does not have to be a specific diagnosis to be eligible. It's just a matter of what is happening in your own life and what is the extent of the toll it's taking on your life, and really how far are you willing to go with treatments and aggressive actions to keep going.
Yeah, and I can't wait to get to the myth busting section. I'll ask each one more question, and then we're going to take a short break and then come back for some additional Q&A. So we talked about eligibility, Jeanne. Let's talk about payer. You mentioned Medicare. Are they the only payers?
Absolutely not. Hospice provides service for any payer. It just so happens that the large majority of individuals that access hospice are Medicare eligible, but hospices can bill Medicaid, they can bill private insurances, and they also work with self-pay and charity care as well.
Great, thank you. And Becky, yeah, I mean, you do more than just we're on the board. You've been a caseworker, you've been in people's homes. Talk firsthand about some of the benefits that you have seen in your past roles for individuals and their families that have enrolled in hospice and are receiving services.
So personally, I've seen many people that have had a death in a clinical setting, like a hospital or a skilled nursing facility, and many that have been able to pass at home. The wonderful thing about hospice, and Jeanne spoke to this, is it's not just clinical care by a nurse or a physician. It's really holistic, family-centered care that also provides licensed social work services. So, we've talked about this on past shows. The family unit and the family dynamic can be very difficult. Hospice is able to really integrate within a family setting and be able to work through some of those things that come up at end of life. They're also able to assist with, funeral services and post-death bereavement services. So to Jeanne's point, if someone is struggling after the death of a loved one, they have continued support. In addition to that, because you are able to remain in your own home or your community of setting and your care team comes to you, there's a level of comfort that you don't see in many of those more clinical settings. And so really just those wraparound services focused on ensuring that what matters to an individual and their family is being taken into account for their care plan, not just their medical condition, I think is one of the amazing benefits of the hospice program.
Yeah, I mean, it's this program and the supports that it provides is like the best kept secret. No reason we should be 50 out of 50 in anything here in New York. So we're talking about end-of-life care. We're going to take a quick break. Some of you might have heard of what's called the MOLST. It's Medical Orders for Life-Sustaining Treatment. It's a document that guides caregivers if they have to make decisions on behalf of a seriously ill person and is a very important part of the conversation at end of life. Take a look at this video and learn more about how you can plan and talk to your clinician so you can develop a roadmap for your end of life. So like anything else, you can't be educated without addressing the myths. You talked about the myth that you have to have a cancer diagnosis, right? But we talked about where that came from. So let's do a little rapid fire myth busting. What are the top myths that you guys see and that need to be addressed?
I'll just jump in with the first myth, which is a belief that you have to go somewhere to receive hospice. And that's totally untrue. Hospice is a unicorn, just like New York State, in that it goes wherever you are. And so regardless of your residence, an assisted living, a nursing home, you could be in a hospital and receive hospice as well. But there are special facilities, hospice inpatient units, that are dedicated to hospice patients who need extreme symptom management. It's short term. It's not a long-term place to stay. It's meant to come in and go out. So that is the only facility. And sometimes a hospice residence, we have several of those in our state. Again, those are meant for people with a shorter prognosis, but they can stay in this residence. But this is all voluntary. You don't have to go anywhere to receive hospice care.
All right. Myth number 2.
The expense of hospice is extremely minimal, if anything at all. So when your benefit is accessed, if you're a Medicare beneficiary or a Medicaid beneficiary, hospice is responsible for paying for everything that is related to the terminal illness and any related conditions. So that means every medication, every piece of durable medical equipment, all the services of the nurses and physicians and social workers, it's all under one lump payment that the hospice receives each day for your care. And there's no cost share with the family. If somebody's on a commercial plan, sometimes there may be a copay that the hospice works with the family on. But that is, again, just a daily small copay that the hospice will negotiate with you.
All right, great. Let's go with number 3. Hospice is only for people with kids. Now, you did that one already. Let's reiterate, that is not true. Let's go to myth number 4. Hospice is only for old people.
So actually, hospice is available to anyone at any age of life. And unfortunately, we do have young people that die, whether they're young in their 30s or they're extremely young in their teens and even younger. Our hospice providers can support families who are encountering these very tragic situations. And even if someone is not ready for hospice, the hospice providers can support families through their palliative care approach. So maybe the child may not and their family may not be ready to say, we're done with aggressive treatment. We got to try everything and hold on to hope. Nobody wants to take that away, but there are ways we can support with consultation.
Okay. Myth 5, hospice and palliative care are the same.
Becky, it's your turn to talk.
Thanks, Jeanne. This is something that we hear quite frequently. And there is a distinction, right? So both of them are laser focused on comfort. Palliative care can begin earlier. It can begin at diagnosis, and it can include that curative treatment process, where hospice is really more for that terminally ill individual that's not looking for further treatment options. These two work hand in hand. A lot of people that start on a palliative care journey then end up transitioning to actual hospice. And to Jeanne's point, about the scope that hospice provides, that's not just for older people. There are a lot of younger people or parents of children who start in the palliative care process and then transition to hospice. That's not mandated. You can have palliative care and seek curative treatment and pass away getting curative treatment. So one is not exclusive of the other, but it's really important for anybody with a chronic health condition that's impacting their quality of life. Palliative care is a tool and a word you should use with your primary care provider to talk about your pain and symptom management. And to Jeanne's point about having these conversations, there are way too many instances where an individual hasn't had these conversations either with their clinician or with their family members, and they end up going through a treatment process that they didn't want to go through. So really important to know that there's a distinction between those two.
Thank you. Myth 6, a physician referral is required. I think we covered it, but reiterate it again.
Anyone can initiate that conversation. And many times, I think it's more beneficial for a family to pick up the phone and make that call than to have them feel like it was pushed on them by a primary care physician or a doctor in a clinical setting, because the family really can take ownership that we've instituted this relationship and are able to move forward. And it allows the feeling for a family to really have control over their long-term care options. But again, I can't reiterate enough that you can absolutely pick up the phone and call your hospice. You do not need a physician referral to do so.
Myth 7, hospice patients are drugged up and die on morphine.
I'll take this myth because this one really bothers me. So every individual on hospice has an opportunity to discuss what their wishes are. And some people they want to be out of pain. That is their primary goal. Maybe they've suffered a long time and haven't been comfortable. And so the hospice will work with the individual and the individual's physicians to go from whether it's aspirin to Tylenol to some Tylenol with codeine. And there's a gradual process to see what works, what keeps the person comfortable. And then if necessary, we get into more controlled substances. And sometimes the first time a person takes the medication, it makes them sleepy until their body begins to tolerate it. And then they come back to where they were before, only without pain. And so it's really important that people know that this is a patient directed. I don't want to be sleepy. I'd rather be uncomfortable because my granddaughter's coming and I want to be as alert as possible. So this is making me sleepy. I don't want that. Then everyone respects this patient-driven choice.
Yeah, and I'm really glad you said that. That's really the focus, is on the person and the family and not somebody making decisions for somebody else. I think we got a couple more myths. Let's go to 8. Hospice is for when there is no hope. Geez, that's not right.
No, there's always hope. And for my own family, I could pray and seek hope for a cure, a miracle, for this not to be so. But as the individual who is experiencing the serious illness, sometimes that hope changes. And the hope is that I know that maybe my end is coming, but I have hope that there's going to be reconciliation with my daughter, that there's hope for no pain, that there's hope for peace. And all these things are a part of what we try and help the individuals get to a place where they feel at peace, and that there is a hope and a belief and a faith as well.
Great. Myth 9, once you choose hospice, there's no turning back.
This is absolutely not true. And I will tell you from my time being a hospital discharge planning social worker, I had many patients that would go on hospice and then change their mind and seek curative care again. It is not you sign a piece of paper and you're in hospice and you're a prisoner and you can't escape. It's absolutely a fluid dynamic. People can choose to enroll in hospice. They can choose to disenroll in hospice. So absolute myth.
Great. And I think this is the last one. Hospice is only for the last few days of life.
Yeah. So I think our culture and our medical culture has helped to perpetuate this myth, because we've made so many advancements in technologies and in treatments and aggressive treatments and what we can offer next, that sometimes there's this sense that someone's on a treadmill or they're on the hamster wheel and they can't get off because there's try this, there's one more thing. And what ends up happening is they keep trying, or they haven't had a conversation with the physicians to say, wait a second, I'm not having any quality here. I want to get off the hamster wheel and think about what are the benefits to the next treatment, and because hospice is supposed to be a 6-month benefit. But unfortunately, the average length of stay in our state, the mean length of stay is 18 days. And yet 40% or more of the people that experience hospice actually die within 14 days. And you think about the benefit was created so that you could get on and experience quality life comfortably and enjoy your family comfortably for 6 months. And so it's up to us to really make people know in our world that we want to talk about what other options exist.
Yeah, and I think the dates that you just, or the days that you just showed versus what was on the last slide and the feedback from the clients, that's where the difference is. They're saying, we wish we had known and gotten on hospice earlier.
Right.
You have 6 months, give or take about, but people are only utilizing it for 2 weeks. So these questions are really for both of you. We talked a little bit about, not all families are what you see on commercials during the holidays, right? They're difficult. So who should be the one to make the decision about electing hospice, and when should they do that?
It's always the personal choice of the individual to determine for themselves. But again, what we recommend is that these conversations start much earlier. You don't have to wait until you feel like you're ready for hospice to talk about maybe wanting hospice when the time comes, and helping your family understand that you're okay with having these conversations, or letting your physicians know, okay, maybe you had a diagnosis a year ago or 2 years ago and you're doing okay, but let's say maybe I want to talk to the physician about what will it look like if things are not going so well, and I want you to know what I want when that happens.
And I think just to tie into Jeanne's comment, I think the most heartbreaking thing for a family or an individual to experience is not knowing what a loved one's wishes were, and then having to make those difficult conversations. And so, again, this ties into length of stay. You're going to get the most benefit from not being on hospice a couple days, but being on hospice for your full 6 months if possible. And what we're seeing is when a late referral is made, sometimes families, get a loved one home for 12 hours and they pass away. That's not the experience that you want to be able to get from your hospice benefit. You want that holistic, person-centered care that includes social work and bereavement to prepare for this part of the journey of life. But, I cannot reiterate enough, families need to have these conversations early and often. They are not a one and done. It's really conversation about meaningful end-of-life care and what your wishes are. And we need to do a much better job in supporting those conversations.
And I think if I could, I'll just add one more thing, which is sometimes we feel like we're burdening our family if we bring the topic up. Maybe it's something that we've been thinking about, whether it's for ourselves or for our parent, but really we're offering this door, this window to what most of us are already thinking. So, to be able to say this is what I've been thinking about, there's often this, oh, thank goodness, because it's been on my mind too, right? And when you think about bereavement and grief, there is so much, there's a healthier grief that comes with knowing that you were following someone's wishes, even if it maybe wasn't exactly what you wanted, than struggling with, did I do the right thing? Because I never talked to them about it.
Yeah, and we just do not do a good job as a country in even recognizing or talking about dying. I mean, it's a normal process of life. And, that's why the most things are so important, and having those conversations in advance so that families aren't guessing, and you're laying out your own personal roadmap, which you have every right to do, on how you want your, last 6 months of your last days to go. If, Becky, you said anybody can call, so I could, but, maybe my parent says to me, this is what I want. Will you make the call? From the time that I pick up the phone and call hospice, how long does it take before the services are turned on?
It depends on the care team and the clinician's agreement, but from the inception of making the phone call to you getting an informational, which is hospice providing you information on the services that they provide, that happens almost instantaneously. So hospices really strive when they get a call from a community member, family member, to say, I'm interested in having what's called an informational meeting. they work to have those done within 24 hours, because obviously if someone is reaching out, there's obviously a question or a need. There's also really robust resources online if you want to do kind of your own homework on hospice and palliative care services. But it's fairly instantly that you're going to get information on your hospice provider and get that informational meeting that to be held.
And go ahead, Jeanne.
I just saw something in the chat.
Yes, I did too. So we'll get to that in a second. I do want to call out one of our regular watchers and listeners, our very own Chemung County. I'm sorry, Beth. Thanks for the comment on your relationship locally. We often throw around the word caregiver. A lot of people don't self-identify as such. So my question is going to be for those family, friends, and neighbors that provide support and care, do they always have to remain with the hospice patient?
Yeah, that's a good question. So the answer is no. First of all, caregiver can be anybody, right? That we said could be anybody that wants to serve and support this individual. And it could be a group of individuals that want to support, and they create a schedule of how they're going to do that. But in terms of having to be present 24/7, the only time that might be something to discuss with the hospice team is when an individual can't get up out of bed. They can't take care of themselves. They can't get a drink of water by themselves. Those are the types of things that need to be considered. But if someone gets on hospice early enough, they're able to say, you can go now. I don't need you staying here. That's perfectly fine.
Awesome. All right, we're going to take another break, and then we're going to come back for some questions and answers. This is hot off the press. We have not announced this yet, but we probably will within the next couple of days. But we're on the verge of something very big. We launched a couple of years ago during the pandemic a partnership with Get Set Up, which is an online tool that helps not only train older adults using peers on the devices that they're using to combat social isolation and loneliness, but provides over 5,000 classes, courses, lifelong learning, exercise, you name it, they do it. We have now exceeded over 1 million classes taken in New York State, and we're so really proud of that. I want to thank the Get Set Up team, partnership with Becky and the association, and everybody who's helped promote that. Check this out. Imagine having access to an online community of your peers, a place where you can explore your interests through hundreds of online classes. Well, that community is available now, right at your fingertips. Hi, my name is Greg Olson, and I'm the director of the New York State Office for Aging. NYSOFA has partnered with Get Set Up, an online platform that helps older adults become more fit, learn to manage their finances, develop new skills, supplement their income, and connect with people all over the world. Best yet, if you're an older adult in New York State, this resource is available to you free of charge with no limits. Do you want to learn more? Well, then visit the link on your screen to explore free classes today and join a community that has already helped nearly 200,000 older New Yorkers stay engaged. So sign up today. All the courses are provided by people over 50, for people over 50, but there's more to it. If you have a special skill, doesn't matter what it is, you can reach out also to Get Set Up and actually provide your skill through their coursework and make a little bit of extra money. So let's get some questions to the audience for our experts here. My area is incredibly lucky to have multiple homes for the dying available for people who can't die at home. How do we promote across the state? Thanks, Jennifer.
So these comfort care homes are all privately run and privately owned. And then hospice comes in as the professionals to help individuals when this comfort care home becomes their place of residence. So we are very fortunate in New York. There are probably over 20 of these comfort care homes now across our state. And so again, if your community wanted to support such a comfort care home, and there are 2 beds, not more than that, because they're not regulated by the Department of Health. there as if you're inviting someone to come live with you. So usually it's a church that has a residence donated, or some not-for-profit community gets a residence that's donated, and then they turn it into a comfort care home with the use of about 200 volunteers to keep it running. So it's quite an endeavor to keep it going.
Wow, thanks. Do I have to stop other medications if I'm in hospice?
Absolutely not. It's pretty easy one.
Okay, there you go. Does hospice include 24/7 care?
The hospice is available 24/7, but they're not present with the patient 24/7. So if a family was thinking that by getting a referral to hospice that someone would actually be there physically to do all the care in the home, that is not accurate. So hospice is built upon supporting the caregiver and the family. It's not built upon replacing the supports that a caregiver and family can provide.
Okay. We just covered that, so let's skip to the next one, Alex. Thank you. Is there any special equipment or changes I have to make in my home for hospice? Good question.
No, nothing has to be done to your home for a patient to stay there. What may happen is that if the patient is advancing in their illness and deteriorating in their function, then the hospice may recommend that it's time to put a hospital bed there. And that might mean, okay, moving some furniture out of the living room and putting the hospital bed there if there's not room to move it somewhere else. But that's probably the major piece of equipment you'd think.
And the wonderful thing about hospice is they take care of those durable medical equipment needs for the family. So any of you that have tried to get, a wheelchair or a hospital bed through standardized insurance, it sometimes can be really difficult. You have to coordinate with the durable medical equipment company. Again, hospice is a package. So that is all taken care of for the individual and for the caregiver, which alleviates caregiver burnout and burden.
Thank you. So before we close, I'm just going to ask you each if there's anything that I didn't ask you that you want to say, or reiterate something that you have said and underscore it because it's really important.
I'll just say to remind yourself and everyone that you come in contact with, you have a right to quality end-of-life care, and hospice is the gold standard of end-of-life care, beyond a shadow of a doubt. And that requires us to talk and to use our voice and advocate for ourselves and our loved ones.
And I would completely agree with my colleague. The other thing that I constantly tell people is give yourself and your family the dignity of choosing your own end-of-life journey. And make sure that in those conversations, you make it abundantly clear what is important to you, what your wishes are, and that way you can alleviate post-death guilt that really becomes a significant mental health concern for caregivers that have to make difficult decisions without knowing whether or not their loved one wanted those done. So give that gift to your family.
Thank you. That's a great point. And I'll leave with, hopefully the next time, we'll do this again, but maybe in a year from now, we move out of the 50th slot because we did a good job collectively in educating people and having that type of conversation. So Jeanne, Becky, can't thank you enough. This is really important. We know as a society, you got to hear things more than once. So we have no issue in coming back to this topic over and over again so that we can make those changes that you guys talked about and get our ranking out of the basement, because that's not New York at all. So our next program is going to be a National Nutrition Month, which actually is right now in March. It's a time when we celebrate New York's nutrition program, and it really happens across the country. New York State oversees and administers the largest nutrition program in the country, serving almost 21 million meals to almost 300,000 people. Our next program, we're going to be joined by St. Lawrence County Office for Aging Director Andrea Montgomery and Director of the Chautauqua County Office for Aging Services, Dana Corwin. They'll talk about the importance of the program. There's several components. And again, just want to shout out to St. Lawrence. We do a March for Meals event in several communities every single year. Becky and I had the honor to be in St. Lawrence County yesterday with Andrea, her amazing staff and volunteers. We prepped food. We went on home delivered meal routes. We served meals at a congregate setting, interacted with individuals. Everybody talked about what a lifesaver, particularly the home delivered meal program is, but also the congregate, where people can come together. They can make friends. They can, talk to each other, combat social isolation. And for those in the community, it's absolutely a lifeline. So we look forward to seeing you on the next show. As always, this production would not be possible without our amazing communications team, Alex, Darren, and Roger. So until then, we'll see you next time.
Live with Greg is a production of the New York State Office for the Aging Communications Bureau. Please join us next time.